Really happy to present on behalf of the whole team the 96-week results of this trial called D3 or Penta 21. And at the end, I will probably ask what is D3 stands for. So the title is Dolutegravir 3TC is non-inferior to Dolutegravir-based 3-drug ART in children with HIV. And for background, you by now know that 2-drug ART regimens, injectables and orals, are emerging alternatives now to standard 3-drug regimens. And from oral drug regimens, Dolutegravir 3TC is now mostly widely used oral regimen in adults, with a huge amount of data on from systematic reviews in trials and real-world data showing excellent efficacy, safety, reassuring results on viral reservoirs and resistance. But data in children were limited to date. The D3 or Penta 21 trial is an open-label, randomized, multicenter 96-week non-inferiority trial which compared Dolutegravir 3TC and Dolutegravir plus 2 NRTIs. In this presentation, I'm going to refer to it as a control arm or Dolutegravir 3DR. And we enrolled children from 2 years to less than 15 years of age, weighing more than 10 kilos, who were virologically suppressed for at least 6 months with no previous treatment failure. Our primary endpoint was confirmed viral rebound above 50 copies per ml by 96 weeks. And we employed so-called smooth away from expected or safe non-inferiority frontier, which means that non-inferiority margin and significance level around it was dependent on the event rate in the control arm and was pre-specified. Visits were 12 weekly with real-time mandatory viral loads at 24, 48, and 96 weeks, and additional viral loads in real times was done as per country guidelines. For example, in European countries, they were done 12 weekly, but in all other sites, retrospective viral loads were done at all other visits on the saved plasma and analyzed for the trial purposes. And we used 2 formulations in the trial. Children under 20 kilos had dispersible tablets, and children from 20 to 25 kilos had either dispersible tablets or adult film-coated tablets. It's dependent on the site, and children above 25 kilos used film-coated tablets. And on the right-hand side, you see the schema. You see that we enrolled 386 kids. Randomization was 1-to-1, was stratified by age group 2 to 6, 6 to 12, or 12 to 15 years of age, also stratified by region, Africa or non-Africa, and the use of Dolutegravir enrollment. So not all children were on Dolutegravir 3DR before enrolling in the trial, and they were allowed, those who were not on Dolutegravir were allowed to switch to Dolutegravir at the time of entry, and we stratified for the time on Dolutegravir, either below 1 month or above 1 month. And the trial was sponsored by Penta and funded by ViiV Healthcare. We also had intensive PK study nested for regulatory submission, and this work has been led by our pharmacology team in Nijmegen, Lisanne, Beves, and others, and published in Lancet HIV. So in terms of baseline characteristics, 386 children were enrolled, 193 in each arm. Our median age was 8.3 years with interquartile range of from 5 to 12 and from 2 years to 15. Weight was 23 kilos, its median weight, and more than half of participants were female. They were immunologically healthy with a median CD4 of 38% and interquartile range of from 33 to 43%. Most of participants, 84%, were already on Dolutegravir more than 1 month at study entry. And for control arm, if you I think it's important to know what an NRTI backbones children were on. 79 or nearly 80% were on abacavir, and just under 20% were on tenofovir. And baseline characteristics were well balanced by arm. On the right-hand side, you can see the countries where participants were enrolled. The vast majority were enrolled in Africa, in Uganda, 74%, South Africa, 15%, Thailand, 9%, and UK and Spain combined 3%. So this is probably the most important slide in this presentation and shows you the primary outcome, intention to treat results. So non-inferiority of dolutegravir 3TC compared to dolutegravir-based 3DR regimen was demonstrated. So this slide shows you the estimated difference between the proportions with confirmed viral load above 50 by week 96. You can see that in dolutegravir 3TC arm, we had 11 children. Dolutegravir 3DR, we have 13 children with viral rebound. The estimated difference in proportions was, point estimate was near a zero with quite tight confidence intervals, which is 99%. And the upper arm of the confidence interval was well below pre-specified margin for the event rate in the control arm, which was 9.5% non-inferiority margin pre-specified. So in the red, you can see per protocol analysis, we had exclude few children because of the protocol deviation. Here you can see Kaplan-Meier estimates and time to viral rebound. In blue, dolutegravir 3TC. In red dotted line is dolutegravir-based 3DR. You can see the lines are really following very closely together with confidence intervals overlapping all the way through. So no difference in time to viral rebound in between two arms. With regards to ART changes, only few children had ART changes during the trial. We had 7 participants or 4 participants in dolutegravir 3TC arm who switched to 3 drug regimens. 6 of them met primary endpoint and 1 was during pregnancy. Out of the 7, 6 remained on dolutegravir-based regimens. In the control arm, 14 participants had ART changes. Most of them were due to simplification or growth. Only 1 participant changed to Biktarvy, it's Bictegravir TAF and FTC for simplification. And out of 14, 13 remained on dolutegravir and had an RTI change for either simplification or for growing. So this shows you resuppression rates following viral load rebound. Most children resuppressed. In dolutegravir 3TC, we had 11 children with confirmed viral load above 50 and 7 children resuppressed to less than 50. 3 resuppressed on dolutegravir 3TC. 3 were switched because clinicians were aware the real-time viral load was done well before 96 weeks, and it was repeated. On repeat, if it was repeated with viral load above 50 per protocol, these participants were changed to dolutegravir-based 3DR. 1 participant was changed to atazanavir-based 3DR is because of concerns regarding the possible risk of dolutegravir resistance and failed samples for resistance. And it's empirically clinicians' decisions was to change to atazanavir. And 4 not resuppressed in 96 weeks. 2 of those had very little time because the first viral load, which was known to clinician, was at around 96 weeks. So by the time children had repeat viral load, and later on probably suppressed or not suppressed, but we analyzed the data just with a cutoff at 96 weeks. We will, of course, analyze with extended follow-up later on. If you look at the control arm, 13 children had confirmed viral load rebound, and 9 of 13 resuppressed to less than 50 at 96 weeks. One child also had confirmed viral load rebound at 96 and had no time to resuppress, and 3 not resuppressed, but they had a similar situation. They may not have very much time because that viral rebound was detected close before 96 weeks. In terms of safety, a very similar number of children with serious adverse events. So if you look at adverse events, we had 11 children dolutegravir 3TC with 15 serious adverse events and 9 children with serious adverse events in the control arm. In terms of grade 3 and above adverse events, that numerically you can see maybe at least a little bit higher number of participants in dolutegravir 3TC, but the difference is non-significant, and infections were the most predominant class with the highest number of adverse events reported. There were no ART-related serious adverse events and only one ART-related grade 3 or above adverse event, which was low-density lipoprotein increase in dolutegravir 3TC arm, most likely because of dolutegravir, not just because of two-drug regimen. And there were no ART-modifying adverse events. We had, unfortunately, one death in dolutegravir 3TC arm, a child with chronic co-pulmonale, and we had one event reported as depression with suicidal ideation in dolutegravir 3 drug-based regimen, and 2 pregnancies in dolutegravir 3TC arm and 1 pregnancy in dolutegravir 3DR arm. This is a slide summarizing INSTI and NRTI resistance among those who had confirmed viral rebound and proportion with emergent resistance mutations to dolutegravir and or NRTI were similar across arms. So if you look at major INSTI resistance, and it's dolutegravir, in dolutegravir 3TC arm, we had 2 dolutegravir resistance, which were including 2 emergent resistance, which are in brackets, and one of those is conferring high-level dolutegravir resistance in one child. And in dolutegravir 3DR in control arm, we had 3 participants with INSTI resistance, including 3 ones with emergent resistance, and again, 1 participant with high-level dolutegravir resistance. In terms of major NRTI mutations, and in dolutegravir 3TC, it's mutations to 3TC. We had 3 children with the mutations identified who had viral rebound, including 1 child with emergent resistance mutation, M184I1 and M184I, and then this is a high-level 3TC resistance. In terms of dolutegravir control arm, 3 out of 9 children, including also 1 child with emergent resistant, and it's L74V, which confers abacavir intermediate resistance. So in terms of acceptability, we saw slightly higher overall participant satisfaction in dolutegravir 3TC arm. These results are very much in progress still. We're looking at all different ways and all different questions. The questionnaires were quite extensive. But if you're looking at the main question, and it was how happy you are overall with this medicine, the majority were both ups happy or very happy at baseline and 96 weeks. If you look at the change, and on the right-hand side, you can see the figure showing you, for example, in dolutegravir 3TC arm, first 2 columns at week 0 and at week 96. You can see that in blue, majority were happy or very happy. But at 96 weeks, this proportion slightly higher, slightly increased, and the majority of those who are indifferent or unhappy slightly decreased. Whereas in the control arm, at the baseline, the same proportion 92% were happy or very happy at baseline, and the proportion at 96 weeks slightly decreased to 88%, and the proportion of those who are indifferent or unhappy slightly increased. I think the changes are quite small, but they're statistically significant. We will be looking at different other ways of looking at this and possible other questions that can help us to identify why can this be the case. But it was an open label study, so probably results can need to be interpreted with caution. In terms of health economics, I think it's quite interesting results, and over 96 weeks, children on both arms had similar healthcare resource use. As you can see in the table, this is the first line is total healthcare costs, and they're very similar, but markedly lower antiretroviral costs on dolutegravir 3TC arm compared to control. And overall antiretroviral costs, if you take the costs based on Global Fund pricing reference from 2025, just to know that quite a few of pediatric formulations are not in this document, and they were estimated based on overall costs. But if you take the best available reference data, you can see that there were much lower costs in dolutegravir 3TC compared to the dolutegravir 3DR, and most of this was due to high cost of abacavir or abacavir containing formulations. So in summary, in children 2 to 15 years, dolutegravir 3TC was non-inferior compared to dolutegravir plus 2 NRTIs in maintaining virological suppression over 96 weeks. Safety profile was similar. Numbers with emergent resistance mutations were similar across arms, and they were very small. And satisfaction with HIV treatment was high in both arms, but marginally higher in the dolutegravir 3TC arm. So switching children who are virologically suppressed, I will show that also save a quite substantial amount of money per child per year. So children who are virologically suppressed on their first-line regimen, as trial shows, can be switched to dolutegravir 3TC. Now, I would like to acknowledge very hard work of everyone in this trial, including sites, trial management team, our trial steering committee and data monitoring committee, who volunteered their time for free, youth trial board, who really supported this trial, and Penta, our sponsor, ViV Healthcare as a funder, and most of all, participants and their families. And we did, through youth trial boards, asked a few questions on experiences and what are the next steps. And the question, for example, the first one was if dolutegravir 3TC works well as 3-drug odds, should children be then now offered if they're virologically suppressed dolutegravir 3TC? And a majority, yes, only one tablet, it's easier to take, less side effects, less medications in the body, etc. The second question we asked whether children should dolutegravir 3TC also be studied in children who are starting ARD, or can we extrapolate from adults? And majority most said that they think children's bodies are different to adults, biologically and clinically different, different immune systems, etc. But it would be also interesting to know about opinions from healthcare workers. And on this, I'll stop sharing, and if anything, I'll share and show additional slides if needed. Thank you.
So it will be a pleasure to present empirical results that were presented at CROI, but also next steps focus on the Valganciclovir effect on infants living with HIV and severe pneumonia. And as it was mentioned, I will present with Samuel Kiobe. So empirical is based on the idea that the high mortality presenting in children living with HIV, but especially in infants. And you can see there from the PEPFAR report that children with less than 1 year have the higher mortality overall. And pneumonia is the leading cause of death in infants living with HIV. And as you know, in WHO guidelines, it's very clear that treatment should cover bacteria. That's why we treat them with gentamicin plus ampicillin or ceftriaxone, and also we cover empirically pneumocystis jirovecii when children have severe pneumonia and are less than 1 year. So the rationale to study both CMV and TB is that they are unrecognized and underdiagnosed causes of death in infants. And you can see this a paper from several years ago, but it was from autopsies in Zambia, evaluating the causes of death in children with severe pneumonia. And you can see there that in the children less than 6 months HIV positive, the second most common cause or diagnosis after PCP was CMV. And also in children less than 1 year, 6 to 11 months, it was CMV in children living with HIV, and also tuberculosis showed up as other causes, okay? So the clinical question was, does the empirical administration of valganciclovir reduce mortality in hospitalized patients with severe pneumonia compared to no valganciclovir treatment? And does the empirical administration of TB treatment reduce the mortality in hospitalized patients with severe pneumonia compared to no TB treatment? We're going to focus only on the valganciclovir effect. But the trial was established on 6 different African countries that are mentioned there. We recruited infants in secondary and tertiary hospitals. We enrolled from March 2020 to January 2024. We had 1 year follow-up that closed in January 25, and we had 558 patients included in the analysis. So the trial was a randomized factorial 2-by-2 control superiority trial, and we focus, as I mentioned, in infants living with HIV hospitalized with severe pneumonia, and the arms would receive standard of care. One arm that was antibiotics for pneumonia, cotrimoxazole and prednisolone, and then ART. That was one arm. The second one was that standard of care plus valganciclovir. The third arm was standard of care plus TB treatment, and the fourth arm was standard of care plus valganciclovir plus TB treatment. So it's a factorial trial. So we analyze both treatments, and the primary outcome was all-cause mortality at day 15, the duration of valganciclovir treatment, and all-cause mortality during the 1 year follow-up. Our study population, this is very important because it shows the fragility of this patient. As you can see, they presented needing oxygen and respiratory support, nasal cannula in 57%, CPAP or mechanical ventilation in 28%. Median age was 4.4 months, so early infancy. Over 60% of the infants had oxygen saturation less than 90%. And you can see that we had a significant proportion of severe malnutrition. So these children not only had advanced HIV disease, but they were seriously ill. You can see that the new HIV diagnosis was in 70% of the infants recruited, and 77% were ART naive. Medium high HIV viral load was very high, over 6 logs, and you can see that the median CD4 percentage was very low, below 15%, median of 15%. But remember that immunosuppression, severe immunosuppression in infants less than a year is below 25%. We study in these infants CMV at baseline and at 15 days, and you can see that the CMV in plasma was very high, a median of 4 logs, between 3 and 5 logs. That is much, much higher than healthy infants. And a total of 400 of the 478 children in which we had CMV viral load were positive. So a very high proportion. But not only that, a total of 51% of them had a CMV viral load attributable to pneumonia based on previous studies that consider CMV pneumonia in those children that have lung disease and a viral load over 4.1 logs. Something that was impressive is that this fragility ended up in a very high mortality in the trial overall. You can see that 45% of the infants died during the long study follow-up, 1-year follow-up. And you can see there that there was a very high early mortality. 24% of them died within the 48 hours, and overall 56% during the initial admission. But also very important is that we had a very high post-discharge mortality. We thought that after saving them from that pneumonia, we could even try to improve their survival, but we had a very high post-discharge mortality. And I want to take one moment of silence really to honor the memory of infants that passed away during the empirical trial and respect for their families. So focusing on the primary endpoint, which is mortality, what we saw first is that the interaction between interventions, between valganciclovir and empirical TB treatment was not statistically significant. Therefore, we consider that the individual effect of each intervention can be interpreted independently. And that is why we focus today on the results of the valganciclovir. We analyzed the 2 arms that had valganciclovir against the 2 arms that did not have valganciclovir. And this is the main result, or the main result slide. You can see that there is a difference in the Kaplan-Meier, and participants treated empirically with valganciclovir had 21% lower hazard of death compared to those not treated. And we analyze, and this is thank you to the statistical team, but also Debbie Ford and Angus help us to analyze this because we saw that there was no proportional effects were observed, and a time-varying effect model was performed as sensitivity analysis. And you can see that valganciclovir is associated with a significantly lower hazard of death during the first month, and you can see in the graph as well as on the table. And this effect diminishes over time, obviously, because valganciclovir is only given during 15 days. We also saw some effect in the secondary endpoints. Mostly, we saw that participants in valganciclovir arms had fewer cumulative days of hospitalization over 1 year of follow-up. Very important, we analyzed the safety. You know that valganciclovir might have an effect essentially on neutrophil and on hemoglobin. And it is true that we saw more cases overall of serious adverse events and neutropenia and anemia effects, but we didn't see a significant increase on children requiring either antimicrobial therapy or taking out their valganciclovir treatment. And also we saw that there were more neutropenia and anemia events in the arms receiving valganciclovir, but again, there were no more children requiring antimicrobial treatment or valganciclovir discontinuation. So the take-home messages of this part of the talk is that infants living with HIV represent a very fragile population, and a substantial number are still missed by programs for the PMTCT, and mortality remains unacceptably high. Pneumonia continues to be a leading cause of death, and the contribution of CMV is highly relevant. Valganciclovir is a safe and effective treatment with a 21% reduction in mortality, a 40% reduction at 15 days, and a 23% reduction in the rate of days of hospitalization, although the effect diminishes over time. And post-discharge mortality is also very high, underscoring the urgent need for targeted interventions after hospital care. And this last sentence is what drives the next steps, and we are going to focus first on support project and then in the empirical plus proposal. So support is based on this idea that we were shocked by the high post-discharge mortality, so we built a proposal to plan supporting the next generation of African researchers on preventing HIV pediatric mortality through a training network. And this is an ongoing EDCTP-funded project in which we focus on support one, to understand the post-discharge mortality in children living with HIV who are hospitalized, and we are doing it with several Penta members in Mozambique, Uganda, Zambia, and Zimbabwe. And focusing on CMV, you can see that we have one fellow that is studying specifically CMV as a post-discharge mortality predictor. We are right now recruiting infants in those 4 countries, and we have reached over 100 already of the 250 expected. And we aim really to assess the impact on CMV viral load as a predictor of post-discharge mortality in children living with HIV. And as I said, fellows are recruiting children, and we are following these children clinically, but also collecting viral load in this fragile population. And then I'm going to have pause here for Samuel to continue the presentation on Empirical Plus. That is a proposal we are launching in the new EDCTP call. Samuel, the floor is yours.
Yes, thank you so much, Pablo. Good morning, good afternoon, and good evening from wherever you are. And so Empirical Plus really is in response to a recent call by the EDCTP, which is a 2-stage call, mainly for a global collaboration, action towards better prevention, treatment, and clinical management of HIV co-infections or comorbidities in Southern Africa. Next. Generally, if you take that slide on the take-home message, it's in response to that take-home message. It's clear that severe pneumonia in infants living with HIV remains a major problem, and definitely in-hospital mortality exceeds nearly 40% despite the standard of care. And CMV, from the data presented, is a recognized major cause of severe pneumonia. And of course, the current treatment guidelines do not provide for either treatment and in this protocol, what we are saying, prevention of CMV-related severe pneumonia. Directly from the empirical trial, we see that 15 days of Valganciclovir reduce the hazard of mortality by about 21%. But what is important is that we still see excess post-discharge mortality when you look at that survival curve. We also find very high rates of readmission, given that very high viral load of CMV that was found in these children, nearly logs above 6. We find that the 15 days of Valganciclovir only reduces that viral log by 2 logs. That means that there is a tail, there's a very high potential for CMV rebound, especially after discharge, which probably could contribute to the post-discharge mortality. And of course, as Pablo has said, this age group remains very, very, very fragile. And from that cohort, we also saw that the CD4 recovery was very slow. And we think that these children may need additional support as they recover from severe pneumonia, especially if it is associated with CMV. So in response to that, next, we wanted to expand over what was done in the empirical trial, and they provide a better approach to CMV, in infants living with HIV less than 1 year, and so who are hospitalized with pneumonia. And here the proposal would be to provide a standard of care, an empirical standard of care, which is 2 weeks of Valganciclovir, and then compare that with 6 weeks of Valganciclovir treatment, followed by 6 months of Valganciclovir prophylaxis. What is new here in the next slide, in the empirical plus, is we are proposing to integrate empirical treatment of CMV plus prevention. So it's a double strategy of treatment and prevention. And of course, the rationale that we are working with is that there is a very high potential for CMV rebound, given that the 15 days effect wears off. Of course, you've seen from the sensitivity analysis that clearly the 15-day effect wears off over time. And so, having studied that period of reduction in the effect, we propose that we extend the treatment for up to 6 weeks with 15 milligrams BD for up to 6 weeks, and then follow that up with 6 months of Valganciclovir once daily prophylaxis for up to 6 months. The primary endpoint here is that we want to look at how many children are alive and out of hospital by the end of the day 222, which is the combined time between 6 weeks and 6 months. Next. Pablo.
Samuel. So this is the final slide. We would like to thank the entire empirical team. That was the first proposal, but also the team and in support, both EDCTP funded projects, but especially the participant children and their families. Thank you.
I am presenting on behalf of an entire team, but happy to share our results from DOLPHIN-KIDS. So I think this group probably very well knows dolutegravir recommended in first and second line ARV treatment with in children living with HIV, 3-HP or 12 weekly doses of rifapentine and isoniazid is also the preferred TB prevention regimen in people of all ages. Dolutegravir is metabolized by UGT1A1 and CYP3A4, which are both induced by rifapentine. In adults, the DOLPHIN study showed that 3-HP could be co-administered with once daily dolutegravir with 2 NRTIs without a dolutegravir dose adjustment. But children clear dolutegravir faster. Dolutegravir exposures from once daily dosing don't perfectly match those of adults receiving the 50 milligram daily dose. And so it was thought that children might require twice daily dosing to really mitigate that induction effect of weekly rifapentine. And that was sort of the impetus for the DOLPHIN-KIDS study. And twice daily dosing, not ideal, as this poses challenges for patients and adherence, but also for program implementation. So we conducted a 2-stage phase 1/2 study to evaluate the pharmacokinetic safety and virologic suppression of dolutegravir with 3-HP in children living with HIV who were virologically suppressed at baseline. So in stage 1, children living with HIV were switched to dolutegravir-based ART with 2 NRTIs. And then during 3-HP treatment, they received twice daily dolutegravir and were followed for an additional 8 weeks. During a planned interim analysis, the PK data were modeled to assess the appropriateness of once daily dolutegravir alongside review of all safety and viral load data. And then in stage 2, either once or twice daily dolutegravir would be tested. And those are the results that I'm going to show you today. We conducted this study in 2 age groups. This was really because of the delay in the availability of 3-HP dosing and a dispersible rifapentine formulation for children less than 2 and less than 10 kilos. This was not done for safety or age de-escalation. And so here we're going to present largely the group of children who were in group 2A, who were at least 10 kilos, who I will spill the beans, got once daily dolutegravir. So for our PK sampling, yes. So PK sampling was done semi-intensive prior to starting HP, and then 3 days after the 3rd HP dose, which based on the adult data was when the dolutegravir troughs were, and when the liver was sort of maximally induced. There were additional sparse sampling of troughs 1 and 5 days post-HP just to confirm that this pattern was the same in children. Our primary objective was to evaluate the effect of rifapentine and INH given once weekly on the PK of dolutegravir. and secondarily to determine the dosing for dolutegravir that achieves target exposures, to describe the safety and tolerability of the two regimens given together, and then to estimate the proportion of participants who maintain viral load suppression, which in this study was defined as less than 50 copies per ml. These are the data from group 1A. So these are the children the 17 children who enrolled into group 1A. So they were at least 2 years old, at least 10 kilos, and received twice daily dolutegravir during 3HP and for 2 weeks after. There were 500 simulations that were performed simulating once daily dolutegravir with 3HP. And that's what's shown here on the left. The blue line represents the median concentration time profile. The green lines are the 5th and 95th percentiles. And then the shaded areas are the 95th percent confidence intervals for each of those lines. And our dosing would be considered acceptable if the lower 95% confidence interval of the observed C trough of dolutegravir was given once daily with 3HP was at least 158 nanograms per ml, which was or is the 5th percentile of the distribution of the 10 milligram dose of dolutegravir from spring 1. The second criteria was that all dolutegravir trough values had to be greater than 64 nanograms per ml, which is the protein adjusted IC90 for dolutegravir. You can see here that all of the lines and largely the 95% confidence, the 95% confidence, all of them are greater than the 5th percentile of 158 nanograms per ml, and they're almost higher than 300 nanograms per ml, which is the geometric mean trough of that distribution. And so we decided to move forward evaluating once daily dolutegravir in children who initially were 2 years and 10 kilos, but eventually just 10 kilos because once we had dosing for children less than 2 years of age. So these are our baseline characteristics for children living with HIV who were at least 10 kilos on daily dolutegravir with 3HP. We enrolled 41 participants, fairly equally distributed across the 3 dolutegravir weight bands. About half were male. There was one child less than 2, more than 10 kilos, but otherwise distributed here as shown, and then fairly high CD4 counts. These are the safety and tolerability data. So there were 7 grade 3 or higher adverse events. None of them were considered drug-related. There were no serious adverse events, and no participants receiving once daily dolutegravir with HP discontinued treatment. There was one participant who was lost to follow-up during HP treatment after all dolutegravir PK. Here are viral load suppression results. So 95% of participants were virally suppressed at study completion. There were 2 who were non-suppressed, the one who was lost to follow-up, and the second participant whose sample was run at a 1:5 dilution. So the lower limit of detection was 20 copies per ml and not 50 copies per ml. And then there were 2 additional participants that were shown here who had viral load elevations that resuppressed after adherence counseling. Here we compare dolutegravir troughs from twice versus once daily dolutegravir. You can see the lower troughs 3 days after the 3rd HP dose. 2 participants had troughs less than the protein adjusted IC90, and the 5th percentile of the observed distribution was less than 158 nanograms per ml. Interestingly, both participants with troughs less than 64 nanograms per ml or the protein-adjusted IC90 struggled with adherence. Both had suppressed viral loads at study completion. So we ask ourselves what the minimum effective dolutegravir concentration is. So the minimal effective dolutegravir dose or trough concentration is not known. Historically, studies have used the geometric mean trough, 300 nanograms per ml, and the 5th percentile, 158 nanograms per ml. of the lowest known efficacious dose, which was 10 milligrams, as studied in the Spring 1 trial. They've also used the PA-IC90, which is 64 nanograms per ml, which is probably the best currently available target we have for dolutegravir concentrations. And this was used in the Radiant trial, which looked at TB treatment with dolutegravir. And then the question we kind of ask ourselves are time limited and infrequent drops in dolutegravir concentrations clinically relevant given the high affinity dolutegravir has for its target? And if all participants who received daily dolutegravir, including those with low troughs, were virally suppressed at study completion. And so we concluded that co-administration of dolutegravir with 2 NRTIs and 3-HP was safe and well tolerated in children who were at least 10 kilos living with HIV. The trough concentrations were significantly reduced, but all participants were virologically suppressed. And so 3-HP can be co-administered with dolutegravir and 2 NRTIs in ART-experienced children who weigh at least 10 kilos without dolutegravir dose adjustment, so long as this is given together with strong adherence counseling. And then, a big question came up about children less than 2 years of age and what we're going to do with them. Unfortunately, in this study, we did enroll 5 children who were less than 2 and less than 10 kilos who received twice daily dolutegravir. But because there were delays in getting doses for 3-HP in this age group, and because there were hard deadlines at the end of the funding period, we were not able to complete group 2A, and we were never able to study once daily dolutegravir in this age and weight group. Here we show data and in the various groups, and what you can see here is that clearance is a little bit lower in children less than 2, but they had similar or higher trough concentrations than the other groups. It's hard to make any definitive conclusions based on 5 children, but at least those 5 children did not have significantly different outcomes than the others. So we may be able to extrapolate this data to children less than 2. I'd just like to acknowledge our funders and a big study team who were all amazing, and I will end there.
So Anna, there was a question around the availability of DTG-3DC formulation and its availability. So Hermione asked around that.
Very quick answer. Dispersible dolutegravir 3TC formulation not yet available, as VIV Healthcare just submitted the dossier for licensing approval to FDA. We expect it to be in 6 months for FDA to approve, and then further probably 6 months for EMA to approve. So, and therefore, the countries may take slightly longer. The dispersible formulation probably will be available in the global north, maybe by the end of 2027. Hopefully then generics will take it on board, though they are really driven by WHO recommendations, and WHO current recommendations, they do include dolutegravir 3TC as an alternative formulation for virologically suppressed adolescents and adults. So that's data I think will support that, but there were no data in children, that recommendation is not kind of extrapolated for children. And therefore, I think it's kind of a balance of good results from the trial versus WHO recommendations. And more maybe like a question to you, because you're sitting on South African guidelines. Would, for example, country guidelines consider, expanding WHO recommendations, introducing international guidelines, because we know that we will need to wait for WHO to update their recommendations for another 2 or maybe more years. And we don't want kind of to wait that long.
Yeah, maybe just to add. So I think one of the other drivers really for this whole thing will really be the cost of it. And certainly I think from the health economic cost, I think if it, there's a significant difference in reduction in cost of, both the adult formulation and the dispersible formulations, because pediatric formulations tend to be much higher cost. So I think that probably would be, this gives quite a bit of reassuring data in terms of the safety and the efficacy of the regimen. I think the driver for country programs, and especially a large country program of South Africa, is really going to be driven by cost. I think, when generic manufacturers make it, and it's cost, and I think that other advantage is it's much smaller tablet, which is easier for kids to take. And then maybe just to add to that, I think really, so James asked a question around, was hepatitis B co-infection excluded? And maybe just to expand on that, how would you envisage it being used in a system, in a health system?
Yeah, so we did screen. Sorry, I forgot to say that we screened for hepatitis B surface antigen, and we did exclude children with positive hepatitis B surface antigen. We didn't have a lot to exclude. We just need to go through the screening data and see if there were actually anyone who was excluded for that reason. We also, like children who with elevated ALTs, screened them a little bit further, kind of whole hepatitis B serology, but we didn't really need to exclude anyone who like surface antigen negative and slightly elevated ALT, that all this kind of extended things that we're doing in the global north, thinking hepatitis B core and antibody, hepatitis B surface antibody, etc. Like, I don't think we saw anybody. I mean, 386 children, maybe not like, a huge amount, but we didn't exclude anyone for those reasons. So we're also going to analyze at the end of the trial, we did another hepatitis B surface antigen just to kind of ensure that whether, we have got any new acquisition of hepatitis B, and that's data to be analyzed. In the trial, we did ask to do hepatitis B serology in anyone with elevated ALTs, and we didn't have any hepatitis B kind of new infection. So in terms of hepatitis B screening, I think it needs to be rolled out in any way, regardless of Dolutegravir 3TC rolling out. It's important to identify these kids. The test is not expensive. It's very available. It's available as point of care. It's available as part of triple elimination. So hopefully that will be rolled out, and maybe the savings that we show with Dolutegravir 3TC can help national guidelines to commit to rolling out screening for hepatitis B. So it's kind of will be overweigh the cost for hepatitis B screening by allowing people to switch adolescents and adults to Dolutegravir 3TC.
Yeah. Okay. No, I think that's something that needs to be included in terms of the total cost of savings and things, and the complexity to the program.
Yeah.
So then maybe just to move on, and we'll maybe come back to, there's a few questions at the end for you, and we will come back and to Pablo and Samuel. I think maybe the first question I wanted to ask was, so the rationale for using 15 days of Valganciclovir. I mean, so what was that based on? And I think we traditionally, I think in South Africa, we use 6 weeks, in terms of our treatment of children with CMV pneumonitis.
No, it's a good question. So we usually use as well in Spain, but we were worried of the empirical approach, giving it to every child, and worried about the possibility safety. So that's why we took a short-term approach.
And yeah, so again, I think the question is really, would that maybe that wasn't the 15 days just wasn't enough to.
Yes, exactly. That's what we think. So we see an effect. We see several things. One of the things we see that has not been presented yet, a clear decrease on the viral load on the children with what were given Valganciclovir, as Samuel presented, so about 2 logs, but that is not enough, not even to reach undetectability. But also, and as you know, yes, we usually give longer treatment, either 4 weeks or 6 weeks. But this safety concern was the one that we really wanted to see if there was an effect, and that is empirical plus. So we are planning to treat for 6 weeks. Yes.
And maybe do you answer or just elaborate on the two questions, Gareth and Anna put regarding
Yes.
the difference in mortality and
So
the question.
it's difficult. So one of the things is on the secondary analysis, I showed the slide showing the benefit on decreasing the number of days hospitalized, but we didn't see an effect on the days of oxygen support in the first hospitalization. Okay, but when we try to analyze, and I copied that slide in the chat, we did a sensitive analysis, and as you know, we can only see trends, but the sample size is not big enough to really consider difference in ART naive or not, higher viral load, or even oxygen support. Over.
Okay. Anna, do you
Yeah, just
elaborate on
wanted
this?
comment, but the actually rate ratio goes the right direction, isn't it? It shows the reduction of oxygen. The like your confidence intervals are like overlapping, but p of 0. It's because of sample size. Maybe like if you had sample size, if you had duration higher, you could have been shown higher results. But I think it's reassuringly for your enable plus that the trend is going the right direction. Not saying more about that, but be very cautious. But we also wanted to understand, because what is driven reduction of in mortality, because we want to understand the mechanism, right? And if it has reduction in a kind of severity of pneumonia, and kind of like, because that's what the hypothesis is, like we wanted to see how this actually reduces helps children to recover from pneumonia. So you want to see that it's they need less support, it's less severe, etc.
Yeah, a very useful thing to demonstrate. And certainly, I think we, like in South Africa, with our children presenting, with a scenario in keeping with a newly diagnosed child with a severe hypoxic pneumonia, we would empirically treat with, for PJP, CMV, and bacteria. And we certainly have seen, just anecdotally, an improvement in outcomes with that approach. So we don't really wait for the CMV viral load to come back to treat those children. And there was just one more question around. So Sibyl asked about, the concern around resistance in that 6 months of prophylaxis. I know, Samuel, you respond. Do you want to expand on that? Yeah.
Yeah, I think it's an issue, but looking at the data, especially from that for empirical treatment, we think that within the first 6 weeks, that should probably reduce the viral load to undetectable levels, and then the maintenance, the preventive dose for 6 months should be sufficient to prevent any resurgence. And again, of course, the emergence of drug resistance is of concern. But when you look at the other protocols, especially those which are using Valganciclovir for for treatment of CMV in transplant patients, we find that there is very, very low emergence of drug resistance, especially for the UL97. Then on the issue of adherence, of course, that's an issue, and we had a very long discussion about this. And there are currently the team, Pablo in Thrive, they are piloting some models and mechanisms of really what would be the best methods to follow participants to ensure that there is better adherence in the community. There is this group in Africa called AfroCap. They have developed several methods for following up participants, especially after post-discharge or even after initiating them on ART, to ensure that there is very high adherence. So those are some of the models and methods, but also in support, we are evaluating something called improved follow-up, where we are looking at closer follow-up of participants to see that there is better adherence to treatment protocols. Yeah, probably you could add something.
No, I think you replied very nicely. In empirical, we have some samples that we're going to analyze that possibility of resistance, and we are considering as well for empirical plus. But I think it's very important, James Nuttall question, thank you, related that is worrying that 15 days of Valgan is remaining the standard of care comparison arm in empirical plus, given the high mortality in empirical. Well, I think on the contrary, James, the problem is that there is no availability of valganciclovir. So what we consider it will be non-ethical to not give at least 15 days, which we show is beneficial and provided because, as you know, it's very expensive even in South Africa and not available in any other country in Sub-Saharan Africa. And we don't know even, I mean, obviously we consider it's safe, but we're going to see if toxicity is higher with prolonged therapy. So we think that is ethical to give 15 days as the new standard of care for empirical plus, but open for discussion. Over.
Thanks. Now, I mean, I'll go to Nicole and maybe come back to that. But I did want to ask around what formulation you were going to use. So Nicole, I think there was a question again from James around. So was the data from Dolphin applicable to children, only children that were biologically suppressed prior to starting 3-HP?
Yeah, so we did that because we were worried about how low the troughs would go and we wanted to keep kids safe. I don't think you have to have a suppressed viral load, but you have to have probably pretty good adherence. If I'm being honest, this was a real group of children. While they were all virologically suppressed at baseline, there was poor adherence throughout the trial, during HP, after HP. There were lots of kids with, there were a couple kids here and there with non-suppressed viral loads, more actually amongst those taking BID dolutegravir, although numbers there are small. You can't make any conclusions from that. And so I really think as long as a child has reasonable adherence, it would be reasonable to start. And I know in a lot of settings, you don't always have access to viral load. I mean, you should, but realistically, there isn't always one in the chart. And I wouldn't let that be a challenge or a barrier to initiating in a child who's otherwise taking their ARVs well.
And I don't know whether Tom, do you want to just come off mute and maybe just speak to this comment around Lisanne's work around DTG-based?
Yeah, no, I appreciated that comment. And I think that's exactly what we think is going on here, and we'll make a strong argument. I'm just always worried in the absence of data that what WHO will end up making their official recommendation and how people will end up implementing that. But we'll see.
Yeah, I think what we looked at when we did the dolutegravir data was really the total percentage time below that IC90, and because of the attachment, it actually a small period of time below IC90 may actually not be of any clinical consequence. But again, I think you do need that adherence to make sure that they're taking that. They can't not take that dose 24 hours later. Because that ends up, you can end up quite low after that. So I think you do need that adherence to be quite high across there. And again, I think there's another question from Nicole. So can you extrapolate that result will be the same for 1 HP?
Yeah, I think that's harder to do. I think the 3-HP is interesting, right? Because the degree of interaction varies throughout the week, right? And there's a nadir 3 days after you give the HP dose, but that wouldn't happen for 1 HP. And so you might expect every day to be that low. So I'm not sure that would work as well. And we're sort of eagerly looking at adult data that are doing that and the RIF data for TB treatment in children. Impact 2024 is evaluating dosing of 1 HP in a phase 1/2 study, and is like the study that won't start. I'm co-leading that with Christy Banieri, and we are evaluating 1 HP with dolutegravir. Right now, the protocol is only written to evaluate twice daily. Dolutegravir, but we said we could amend pending emerging data from adults.
Thank you everyone for their time and their questions. There's still quite a bit of questions on in the chat, and unfortunately we've run out of time. And it's always interesting when we have so many questions and such interesting presentations. So I'll say thank you very much to everyone who's, all our presenters for their excellent presentations, and everyone for joining and their amazing questions and their and the interest in improving the overall outcome for children living with HIV and TB, both in the north, but also outside of in the global south as well.